All right, so welcome to the impromptu shoulder lab. What we're going to do here is run through all the exercises and the content here, and then hopefully at some point later in the semester we'll be able to play around with a few of these exercises. The first exercise is going to be seated eccentric loading of the posterior rotator cuff. And so from the musculature standpoint, it's precisely the musculature is in the name, posterior rotator cuff. What are those two muscles? Infraspinatus, teres minor, exactly. And so what I want you to do to start before you get into this, if you're able to try this with somebody here, prop up the patient's arm, start within 90 degrees, just straight 90 degrees of abduction here. And I have this is before we had the tables that go up and down. So in lab, we just do it on the actual table here. So you don't need these little risers. Start with the patient's shoulder and just 90 degrees of abduction. And what you'll do is you'll take your hand and just start on the scapula and move it towards the glenohumeral joint. What you'll typically feel is a little hollowing or an indentation, right? That's decentration of the glenohumeral joint. Okay. What you'll do is you'll either keep your fingers there, or you can place your thumb there and just rest your fingers on top of the shoulder and start to adduct the arm. So bring the arm more forward into the scapular plane. And then what you'll notice is when you get into the scapular plane, you'll notice that the humerus actually almost kind of pokes out. Or pokes back or falls back. That's actually the humerus positioning appropriately in the glenoid for optimal co-contraction around the joint. And those of you that are in lab were able to actually physically see that, feel it in this exercise, but physically see it in the next exercise, a low diagonal sit. So what you'll do here is sometimes, a patient has a really flat thoracic spine. That means like baseball pitchers and golfers, like elite baseball pitchers and golfers, T-spine be so flat, so the scapula is actually going to be more, it's going to be more in the frontal plane here. So their scapular plane may be that 90 degrees. So you don't know. Now, on the flip side of that, some patients have really have a seasoned thoracic spine, so the arm is going to be more adducted, and their scapular plane might actually be almost 90 degrees of forward flexion. So it really depends on the patient. That's why it's important for you to kind of feel that and find that patient's scapular plane. Now, once you get there, okay, have the patient relax. The deltoid should be completely off. Well, what I used to say is, hey, can you resist me? But nobody can resist me. So now I say, meet my resistance. So they'll push into me a little bit, and I'll say, okay, now let me win. And so they're really focusing on letting me win as we go start to eccentrically load the posterior rotator cuff here. And it's honestly, it's very, very light. It's not a lot of resistance, right? And so I say, let me win. And if they're resisting me too much, I'll say, hey, let me win even more. And so it's really slow here. So slow loading and eccentric loading. I'm not trying to crank them into passive external rotation, and I'm actually not trying to crank them in a ton of internal rotation either. Notice I don't even finish the internal rotation here, and I take Dr. DMET back up into external rotation passively. This is not a resisted external rotation. Passively bring there, and then we eccentrically load. I might do a couple of reps there. And I'm feeling for tonic muscle dominance here in the shoulder. Okay, that's my big biomechanical fault here is elevation of the scapula. When resisting here, too much resistance, too much crank, those are biomechanical faults as well. So we're not cranking external rotation, we're not cranking internal rotation, we're not even cranking a soldier boy. We're just working within that range, okay? Another one is coming into too much external rotation. The patient goes into open scissor posture. And so now let's say we'll have a couple. That's a fault there. I don't want that. Elevation of the scapula. I don't want that. Deltoid should be quiet. I don't want that decentration of the humerus. I need that humerus in the scapular plane, patient scapular plane. Now, let's talk about this for a second here. So, is this a strength exercise? Well, no, it's not a strength exercise. So, it doesn't follow the rule of 10 or rule of 15 and 25. Is this a pattern exercise? Well, no, it's not a pattern exercise. Is this a facilitation exercise? Kinda. So we're doing this to try and increase a little bit activity in the posterior musculature, so maybe increase the attractor state in the posterior rotator cuff musculature. but it's not a true facilitation exercise. So it doesn't necessarily follow the facilitation repetitions, okay, that are anywhere from 8 to 15 repetitions per set. But the goal is almost like a facilitation for the posterior cuff musculature. So it technically is a facilitation exercise, but you have to say that it doesn't follow the constraints, or it doesn't follow the regular programming of a facilitation exercise. So it's more of a minimal effective dose, with the caveat of for facilitation, you may or may not hit 8 to 15 repetitions depending on the patient's ability. So some patients may fatigue out after 3 reps. Some patients may be able to do multiple sets of 10. Honestly, it just really depends on the patient. Okay, next exercise here, low diagonal sit. All right, so I love this position in general just for quality rehabilitation, okay, especially for the hip. Now, we're going to be doing this for this lecture. We're going to be doing it for the shoulder here. And now, so just getting the shoulder into a centrated position is for some people, they'll make them sweat physically. And then what you'll see too is quite often is when they get in this position, you'll see the anterior deltoid very defined, okay? And even you'll see the lateral head of the deltoid pretty defined, but it'll almost be like they don't have a posterior head of the deltoid until you start to do what's called a shoulder hinge, okay? So you start to hinge the shoulder back. That takes the humerus and it positions it in the glenoid to create quality co-contraction around the joint. So you'll see some musculature tone decrease in the anterior deltoid, and it'll increase in the posterior deltoid to where it looks like they have a full deltoid, which they do. It just depends on what the joint position is. And so getting into this here, the first things first here. Now there's multiple parts of this, right? So we have the joint centration part, which is this. Then we have the assisted lowering portion. Now when we get into the assisted lowering portion, my tissue that I'm targeting kind of changes depending on what I'm actually doing. So I'll just cover the joint centration portion here. I don't want that, which is going to be what everybody does naturally. I want that. That's my starting position. Okay. Now, if I'm actively, okay, so I'm assisting them into the shoulder hinge, right? What I'm going to do is, what you'll do here, I didn't do it with Dr. Demack, but what you'll do here for all your patients is you'll have them take their offhand and place it on the chest there to protect any type of tissue boundary. Okay. This hand is actually going to go on the thoracic cage. Okay. It's not on the humerus. Okay. So you're not on the anterior portion of the shoulder. You're actually more proximal. All right. This hand, in this scenario, my left hand, is actually going to be on the scapula. The only thing that's going to be in the humerus are maybe like 2 fingers to guide the humerus down, make sure we're hinging through that hand, okay? Or through the shoulder rather. Outside foot is back, so I can have a wider stance if I have somebody who's bigger, like myself. If Dr. Demack was doing this on me, she can do this on me because of her foot stance, okay? If I have my feet the other way, then I'm at a disadvantage from a mechanical standpoint. Now, you've probably heard the phrase, okay? I think I actually do this incorrect here in a second. I'll point that out though. You've probably heard the phrase in talking about how the humerus interacts with the glenoid. So if there's a glenoid in the humerus, right? It's like a golf ball sitting on a tee. That's why the labrum is so important to create more stability. So it's really like a golf ball and a tee, very shallow, but the labrum allows for more coverage over the humerus, right? So what you're going to do is you're going to traction the tee off the tee is the scapula, the tee off the golf ball as you're taking through this. So we're tractioning superior the whole entire time. So I'm there and I guide. I don't push into that, okay? I guide. Now, she's not doing any work. This is passive, okay? She feels a stretch in the posterior aspect of the shoulder here. I should have my finger off of her humerus right here. That's my bad there, okay? It's an old video. I should have my finger off here. I'm tractioning to the ceiling the entire time, okay? If I'm doing this for mobility, okay, the tissue I'm targeting, if we're doing this passive, is the posterior capsule, because we're creating stretch in the posterior capsule. Now, if you hear a sound, an audible, maybe you hear like something like a almost sounds like a cavitation or something that's close to a cavitation. Don't fret, friend. You don't have to actively contract your S5 dermatome. This is not a problem. Sometimes it's just a cavitation. Sometimes it's just you're literally exposing the glenoid to humerus that hasn't probably explored that position in a long time. That's okay. Now, if I let go, if I take her in this position and I let go, like right now, if I unload the shoulder now she's actively going to be holding herself up in this position. She's going to be working the posterior rotator cuff, a little bit posterior deltoid too, but really infraspinatus and teres minor and posterior deltoid. The big thing here is look at her control in the frontal plane of the rib cage. The primary fault of getting into this here is patients are going to lose their rib stacking between in the frontal plane between the rib cage and the pelvis. So they'll dip the rib cage down to the floor. That is the primary fault. That's the biggest fault here. Now, I can also add some concentric pressure too. So I'm resisting her as she's coming up here, making sure she's staying centrated. Again, if I'm passively taking the patient in this position here, this is going to be for the posterior capsule. If I'm take her in the position and I'm resisting her, or she's controlling the eccentric loading down here, and maybe I'm just guiding a little bit, that's going to be musculature. So it really depends on the context of what we're doing, what you're doing as assisting here. So we're doing this for muscular activity here. Great job of keeping the stability in the frontal plane. She's doing a good job keeping the cervical spine in a relatively good position as well. Okay, now we can get into the active portion here. Oh, that's another thing too. If you're lowering there, one thing you don't want to do is you don't want to have the patient just kind of almost like keep the chest open to the ceiling. We don't want that. We want the chest to be relatively angled down a little bit, because that, not down necessarily, but down and forward there. And we don't want to close too much. Okay. So again, I don't want too much of that because it turns into an ab exercise. Also, I don't want too much rotation of the chest there. I want a good shoulder hinge like I just demonstrated there. Now, can she actively do it? Now, pause here. This is really hard because she's in low diagonal sit. So if we're going to actively eccentrically lower here, okay, so not assisting anymore, she's actively doing it, she needs to switch her feet into what's called low oblique sit, which I end up doing later in this video. She's cheating with her hand. I gave her a little bit more space, so she now has a little bit more confidence in falling there. Big thing is, can she keep the rib cage? That is rock star. That is incredible, especially in low diagonal sit. That is phenomenal. Now, low oblique sit, she's going to own it here. And I'm going to give her the pause. Okay. Pause. And so what she's doing right there, okay, you can pause your patients to create a little bit more attractor state around specific joint angles. Okay, you have these options here. All right. So in terms of rep sets here, if you're doing for mobility, then obviously it's going to be a little bit it's going to be minimal effective dose. What's the minimal amount I can get the maximum mobility? If you're going to do muscle for muscle work here, again, it's going to be kind of probably facilitation. But again, it's the same context as the seated eccentric loading of the posterior rotator cuff. A lot of people aren't going to be able to do a ton of repetitions. So really minimal effective dose for it to get the maximum facilitation. Is a little kind of curveball exercises. Okay, they don't follow the guidelines that we've painted already in the load management lectures. Okay. Serratus wall slides. I really like serratus wall slides to really pattern upward rotation of the scapula. So that's the goal of this exercise, the pattern upward rotation of the scapula. Now, the musculature that you're going to be focusing on, one of them is actually the names in the exercise, the serratus anterior. But there's other musculatures that you're going to be focusing on here as well. The primary one is serratus anterior. But the other musculatures are going to be the musculature that are creating upward rotation of the scapula. Those are the upper trap and lower trapezius, right? A little bit of middle trapezius, but nothing to really to write home about. But the three main ones are going to be upper trapezius, lower trapezius, and the serratus anterior. Now, the reason why people, we want the feels in the serratus anterior here. And so I always ask students, like, why do you think we only feel the serratus anterior in this exercise? And they typically look at me with a blank face, and I tell them, which ones do you think of those three musculature, which ones do you think you use the least? It's serratus anterior, it's obvious, right? And so what this exercise does, because of the band placement, it makes you actively engage the serratus anterior, because the external focus of not letting the band roll up the back makes you activate the serratus anterior. So the external focus of the band actually allows for upward rotation of the scapula. The big thing here is not standing too close and not standing too far away. Now, if the patient feels their deltoid or their bicep tendon working a little bit too much here, typically what's going to happen is the patient's too far away. Now, if the patient's standing with their feet together and they're in a good distance, it's going to be kind of hard to get that good pattern as well. One with feet shoulder width or hip width, okay? Whatever the patient feels comfortable with. Again, the cue is to slide the foam roller up the wall and don't let the band slide up the back. Keep giving the cue of the band sliding up the back here. So your eyes are going to be on the cervical spine. Your eyes are on the scapula here. Make sure there's no elevation of the scapula here. So this is a pattern exercise. So that means my repetitions per set are going to be anywhere from 5 to 8 repetitions. Now, let me caveat here, for any pattern exercise, okay? If they're kicking the pattern exercise's butt, let's load it. Honestly, if you have a set of 8 planned and after 5, they're just killing it, stop, say, okay, that's good. Let's load it now. So try and seal it with some type of load, right? That's our strength pat. Now we're going into strength exercise, right? So remember, fire, wire, seal, facilitation, pattern, strength. Okay, because if we can, the goal in the end is to get to loading. Now, if we can get to loading faster, because we don't need to spend a ton of time on patterning the exercise, then we do that. Okay, again, another fault other than elevation of the scapula here, maybe protraction of cervical spine. Another fault is trying to flex the arms too much. Okay, sometimes like Dr. Demack has too much tension on the band here. Probably you notice her arms coming in a little bit here. I want forearms roughly vertical. Watch her humerus go into internal rotation as she come up, because she does this, because she has too much tension on the band. That's why I stopped her from going into so much flexion. Okay, I love following up serratus wall slides with half kneeling landmine press. Okay, half kneeling landmine press is a strength exercise. Okay, is this full body or is this half body / single limb? This is obviously a single limb exercise. So that means rule of 15 to 25 per set per arm or per leg. Okay, what's per arm in this scenario? So again, this is a strength exercise. And so what I'm gonna have the patient do here is the patient's gonna hold the end of the barbell. Okay, we have to hold the end of the barbell, not halfway up the sleeve here. You're gonna hold the end of the sleeve. Okay, and the position is going to be, she probably needs to come forward just a touch more, because the position I want is the barbell would be resting just below the clavicle, essentially, right? And so what we'll have the patient do is we create tension in the opposite hand here, and I'll have the patient slowly yeet a couple reps here, okay? And I'm walking around looking for elevation of the scapula, which is a primary fault here. And also another common fault here is coming midline, as you press, coming midline with the barbell. Okay, I want a good spacing between the arm and the head here. Now, if I place my hands on the barbell, the exercise turns into a patterning exercise. So if I have the patient just do a couple reps, it's a strength exercise. But if I place my hands on the barbell to alter the path or of the barbell or the biomechanics of the shoulder, it is now turned into a patterning exercise, okay? And so if I see either early elevation of the scapula instead of upward rotation of the scapula, or if I notice or the patient complains of pain as they eccentrically lower the weight here, I'm going to grab the barbell and I'll do I'll do active negatives or pulls. Essentially, it turns into a vertical or horizontal or whatever you want to call it, pull instead of a push, okay? And so what we're doing is we're sprinkling a little cage of magic on that shoulder, creating a little better activation of the posterior shoulder musculature here, maybe some lat, but specifically lower trap here, to actually create better shoulder mechanics in the press. Okay, so I actively pull. I might do 3 or 4 reps there, and then I'll have the patient press again. And quite often, even if they don't have shoulder complaints, you'll find that they actually feel better. It feels better. Okay, so I got some resistance there. Now, if the patient's coming towards midline here, I have 2 options for an implicit coaching strategy. Okay, I can stand on the inside of the barbell, so I'd be kind of face to face with the patient, obviously socially distanced. But as they press, my body's against the barbell, so they have to follow the line of my body. So they have to stay wider instead of coming across the middle, okay? Or what I can do, if I want a little bit more posterior rotator cuff or posterior deltoid activity, I'll try and feed the mistake. So I'll pull the barbell towards the midline slightly and say, don't let me pull the barbell in, or don't let me push the barbell in. And so reactively, they'll push out as they're pressing. That creates a lot more activity in the posterior deltoid. It really depends on the diagnosis that you're trying to load, or the condition that you're trying to load. But I like pressing with that down knee to the same knee, ipsilateral knee down that we're pressing to. Shake it out a little bit. Okay, again, it's a strength exercise if my hands are not on it. Okay, and if the patient can knock that out, then we do our rule of 15 to 25. My hand comes on the barbell, then it turns into a patterning exercise. Turns into a patterning exercise. Okay, so I don't want sticking the head through the hole. I don't want coming across midline. I don't want elevation of the scapula. Good space between the arm and the ear. I want that. Okay, now, primary musculature, this exercise is working. We're looking at anterior deltoid and pec major, okay, with a little bit of tricep as well, finishing that elbow extension. Those are the primary musculatures here, okay? All right, half kneeling overhead press. Now, if I have the band in my hand, I'm working on pattern, all right? But understand that depending on the strength of your patient, the band might be the load that they need for their strength, okay? So it kind of depends on the strength of the patient, right? But for Dr. DMAC, she's strong, fam. She's so strong. So we'll use the band for patterning here. Now, you don't have to use the band for patterning, okay? If you notice that you need to work on a little bit of patterning stuff, or if you feel more comfortable doing a couple patterning repetitions before you apply the load here, then we'll do that. But when we do this here, you'll open the end of the band first. Then you place the band really close, okay? Place the band really close behind, that's anchored just behind their shoulder. Too many people are anchoring the band closer to the foot, and so that creates a steeper angle, so that'll cause more forward flexion of the arm. I want the arm to be directly over the shoulder when they finish the press. So after I stand on the band, hand goes through the band's on the outside portion of the arm, so when they press, they're going to finish with the palm forward and the band's behind, just like a kettlebell with the weight behind the shoulder here, okay? I love half kneeling overhead press with the kettlebell. Oops. I love half kneeling overhead press with the kettlebell because the weight is behind the shoulder. Okay, so I feel like we get a little bit more scapular loading in this press here. Okay, once that's good with the band here, we can end up taking the band off here. We don't have to do a ton of reps here. We can end up taking the band off and do, I don't want to, now here's the deal. I don't want to go out here and press here. I'm okay with coming out and then pressing up here. You don't have to press like this, okay? I'm okay with coming out a little bit as we press up. I just don't want to go out, then up. I don't want to stay out here. It's a 1-to-1 press to rotation ratio. It depends on your humeral length, excuse me, your humeral length, and well, I guess shoulder width as well. I don't want like an Arnold press. And I don't want the elbow to kick straight out first. It becomes more of a tricep extension. She's doing great there. So I want to load it here with the kettlebell. The rack position is the kettlebell is in contact with the pec, bicep, and forearm. And I'm monitoring position of the kettlebell. That's perfect press there. She should be making a fist with that right hand. Okay, creating tension. Boom. Press. Killed it. Okay, my rep sets here. This is a single arm strength exercise, right? If I'm just doing with the kettlebell, then I'm following the rule of 15 to 25 per of total volume per limb in this case. Okay. Primary musculature I'm working is the deltoid. Okay, that's what's causing the overhead press here, and you get a little bit of tricep in there as well, finishing the elbow extension. 2 hands going down. Good hinge, Dr. DMAC. High five. That's a good connection. Okay. And finally, we have the bent over row. I love this exercise for shoulder patients, just like I love it for low back pain patients as well. I like it for low back pain patients because it gives the patient something they can do in the gym that doesn't hurt their back. They can do other exercises safely. I like it for shoulder because, well, it creates good rowing patterns, good shoulder placement and loading. And the target musculature is the latissimus dorsi for this. This is going to be a strength exercise. So we're looking at rule of 15 to 25 again, since it's a single limb exercise here. Obviously, the big biomechanical fault is going to be pulling too high into the armpit or even to the rib cage, not pulling to that belt loop or, as we say, pulling a 6-shooter out of the holster. I do like the the lifter's wedge here. Oops. Silverback gorilla position here. Ipsilateral foot that I'm rowing to. There's drop back a little bit more to clear room to pull that kettlebell. I'm trying to tear the rubber mat in half with my feet, flat feet, but trying to rip it in half, shoving the platform into the ground here. Silverback gorilla, and pull that sucker, pull a 6-shooter holster. I'm okay with rotation at the top, okay? I'm okay with rotation at the top. There, see my shoulders rotate? I'm okay there. It's when it comes down. Don't rest the kettlebell on the ground. I don't want rotation here. Shoulders should start even, and they should finish rotation here, okay? So I want you to watch where the kettlebell starts in relation to my center of mass, okay? See, it starts under the shoulder, but when I pull, it moves back here. So there's actual change vertically when I'm doing a horizontal, vertical in relation to my torso, when I do a horizontal movement. That applies for pressing and pulling. So it changes the angle. Now showing it from the backside here. There, trying to spread the floor, shove that into the ground. That elbow is really tight here. I'm not cueing that. I want to be able to hear the shirt slide against the sleeve of the shirt, slide against the body shirt. Let's see if you can hear it. Curious. Barely. Can't really hear it too loud. Too far away. Okay. All right, guys. That is it. Enjoy.